So welcome everybody to episode 20 of the HCBiz show. Really excited today. We've got a guest in Dr. Justin Smith here who's actually doing a lot of what everybody on the internet is constantly talking about doing in healthcare. And specifically, there's so much stuff that I want to talk to you about. I won't waste too much time on a setup, but it's kind of a nice pathway where you go from the social media engagement of the patient community and how you've used that to source ideas and how you're just generally speaking, the approach you're taking to, I'll say the word innovation, but the approach to just trying new things to see if you can provide better care to your patients, and being willing to take shots and having the support of the hospital system behind you on that. Really cool story. And like I said, I'm just going to dive right into it. But I wanted to do a quick intro here for my co-host Shahid, Shah. I know this is an area you've been working on as well, I believe, somewhere in the country. And I want to see if you had any additional setup you wanted to throw out there.
Yeah, just only setup, Justin, thanks for joining us. I mean, having somebody who's actually not just pontificating about all this, but actually doing something about it and listening to patients is both fascinating and welcome. So thank you for doing this. The only setup I would add is that we are, as I'm an advisor to AHIP, America's Health Insurance Plans Association's Innovation Lab, and a number of plans come in, and especially in the Medicaid community, what they're trying to figure out is, what does the clinic of the future look like when you're trying to accommodate and deal with people who can't just get into a car and drive anywhere that they want to go, who are looking at if they need to take an hour away from work, that's a good chunk of their both time as well as income. If they need to get prescription drugs, it may be farther away than they want it to be. So now this is not just about homeless care or anything like that. I mean, there are a group of people who just can't go in the same way that other groups of people can. So we're trying to learn as much as we can about, one of the platforms, which is why I'm really excited about working, listening to what you have to say, Justin, here is what does the practice of the future look like when it's designed by patients? Perfect place to start. But then what would that look like if there were some forward-leaning healthcare plans that said, yes, we're willing to throw away our old notions of, pre-existing, pre-authorizations, these old notions of I need to know precisely what you're doing with services, and that's how I'm going to reimburse you. So I'm not saying that, there are health plans that are ready to switch over today, but if we can come up with something, we've got a plan, we've got people who are trying to experiment. I just spoke to another physician on Monday, and maybe we'll put him on a future blab post here, who wants to do something like what Justin is working on, except in partnership with payers. So that was my only setup. So Justin, as you're speaking to us, let us know if there are innovative health plans listening out there. What would you ask them to help you with?
Sure. Yeah, and I think innovating across the spectrum of need, from our Medicaid providers to our commercial payers, is important. So we actually will take Medicaid in our clinic, and we'll be innovating in that space as well. One of the benefits I have is being part of a health system, and we'll talk about this in other aspects too, but we didn't talk to Don about it, is that Cook Children's does have a Medicaid plan. So I have the benefit of being able to leverage the Cook Children's health plan guys that I talk to, almost every day, to say, hey, I'd like to try this. Will you pay for it? And can we demonstrate cost savings for you? So I almost have like my own little insurance plan that I do get to work alongside. So it works out great. That way it is Medicaid, but it's still the same. I mean, they still want to save money. They still want to keep costs low. They still, so we're working along the same idea. So it's
that's great.
It's a great sort of caveat to the topic as well.
Good. So just for the HCBiz community, because we do focus a lot on the business of healthcare. So this new idea of provider-led plans is making a comeback. It used to be payer-led plans, and then it went to providers a little bit, and then payers took off again. And now they're saying that because of the new data, population health, things that only providers can know about their population, if you put providers in charge, and then plans back them up with the best back-end systems, admin, payments, et cetera, that might be a more successful model. So if you do any searches for provider-led plans, you'll find a little bit more insight that Justin was just talking about. So with that, Don, take over. Today, I wanna just learn from Justin.
Awesome. All right, thanks, guys. So real quick, Justin, just to make sure that everybody knows who you are and where you're coming from. Quick intro for yourself. Who are you? What do you do? Where do you work?
So I'm a general pediatrician with Cook Children's Medical Center or Health System in Fort Worth, Texas. So we are a private but nonprofit hospital here in Fort Worth. So we really function like an academic center in that we have research. The only thing that we don't have is residents and students full time. We all take on students from time to time, even residents coming from sort of nearby programs, but none of us have that as a primary responsibility. I've been working here for almost 3 years, coming up on it. I was a private pediatrician out in West Texas where I had to do everything from office to hospital and NICU and PICU and everything else. So I have a pretty broad background. I did that for 4 years. So I kind of learned really the gamut of medicine and what we have to do and how it's inconvenient for parents to be expected to just drop into a specialist because it was a 3-hour drive over here to Fort Worth. I came over here with I needed to move for family reasons, so I had a really successful practice there. But we moved this direction, knew because of my relationship with Cooks that this would be the place I would want to work if I moved this way. So I knew I was going to be joining Cooks when I got here. And about a year in, they recognized that I had some sort of special knowledge of blogging and social media. And so I was kind of doing that on my own. And rather than shut me down, they took a really proactive approach and said, actually, we're going to bring you on. They called for a meeting. I thought they were going to be shutting me down. And they said, actually, no, we want to bring you on the marketing team. We want to make you part of the team so that you can be a medical advisor for us, help us find topics, write for us regularly, and then sort of be a voice for the system. And because of that, of course, I already had a growing social media presence, but it, of course, exploded after that, having the hospital backing me up. We were one of the really early adopters of that model and did it in a way where I really became a part of the team. So about a year after that, so it would have been right out a year ago, they recognized through sort of my writing and what I've been talking that I definitely had a heart for patients and a heart for doing things differently, and then sort of a bent towards using technology. And so they came and said, hey, we'd really like for you to start your own clinic. We'd really like for you to be the medical director of a clinic so that you can make a decision and take on and change tomorrow instead of having to get a whole group on board. And so that's a year in. We are still working on that process, and I'm hoping that we'll open October and November. And so that's kind of where we sit right now. Right now, I kind of float through different clinics and work, part-time in this clinic, part-time in that clinic, and then spend quite a bit of time designing and implementing this new clinic. So,
awesome, thank you for that. And that clinic that you're building obviously is a big part of the background story here and why we asked you to come on and what we want to talk about. So to set that up, what specifically was the problem that the healthcare system was trying to solve when they came to you and said, we want you to build this clinic and make it the medical director? What is the end goal of building this clinic, and what are you guys trying to accomplish?
So I think there's several different reasons. I think the first one was they recognize that there are new technologies out there and that they aren't really being implemented in this primary care world. We see a lot of innovation for disease-specific conditions, and that's where it seems like there's a lot of focus, but it only reaches a small set of our population. Certainly, we need to be working in those fields and doing work there, but because we have so many general pediatricians in our system, I think we're on to like almost 20 clinics now and over 100 general pediatricians. A lot of the patients that we see, never ever go to our medical center, and so they wanted a place where we could innovate for them and sort of make that experience the best it could possibly be. Mm-hmm. They also wanted a place where everybody could play, in a sense that not just the physicians, but marketing or process improvement or legal, if they had some ideas that they might want to implement, but implementing them across the system with 100 providers is expensive and difficult. But if instead we could implement it with just me in a clinic and it works, and then we scale it out, that's a much easier model and much easier barrier to jump over. So those would be the two main things, is sort of patient-centered and finding a way to make our primary care more patient-friendly, and then secondarily to spread innovation throughout the system quickly.
So Justin, can you think of an example that might help some of your physician colleagues to say, in our model, we're able to do this faster, like maybe an example of what that faster is, or better, or more quick to get to outcomes, rather than if they don't have an experimental approach? Because I think what's nice about it is it's an agile experimental approach rather than a top-down, here's what we think you should go do. Let's run a thesis on it, and then let's design a clinical trial, and then let's run the trial, and then by the time you finish the trial, you've forgotten what the heck you were trying to do. So give us an example of what's worked and why there.
Yeah, so even before we've opened, I've been able to demo several tools and ideas, and one of the ones we demoed is CellScope, which is the attachment to the iPhone that allows parents to capture ear exams at home and then ship them over to the pediatrician. And because I have active patients that I'm seeing, day in and day out, I was able to offer that to some patients. We ran a pilot to determine if it was clinically feasible. Then we ran it live for a couple of months, and I got enough exams and got paid on those exams. And then we said, hey, look, this has worked. Let's go. Let's just go ahead and offer it. So we are really close to having that ready to roll out to any provider in our system that wants to have it. So the cool thing about it is I can go to a company and say, hey, I'd like to try your equipment. It's just me. So, it's only me. I'm going to only be the one trying it. But if it works, I'm going to be offering this to over 100 primary care physicians. All of a sudden you have this leverage with this company that, just a group of 5 people doesn't have, but I have the flexibility and the agility of just being one who needs to try it. Is I don't need to ask for 100 demo units from a company. I just need one. And then if it works, then we're gonna buy a bunch from you. We're gonna start partnering. So we go all from being in this small pilot to often the biggest group of providers for that technology because we are so big in the primary care world.
How did the pilot design work in that case? So is that a typical design that an independent review board would have to approve? Or you're just talking about a simple pilot that you got some basic agreement locally, but not some official, clinical trial or something like that?
We certainly have IRB. So if we had something that was more of a trial like that, then where there was a treatment and looking for a desired outcome, but we're just really doing more feasibility studies. Is this feasible clinically? Can I get the clinical information I need if that's the type of pilot we're talking about? And is it feasible that it could scale up to the whole system without killing our workflow or losing revenue? Because I can't say to my 99 other providers, and I'm just guessing on the number, I forget, it changes all the time, but I can't go to them and say, hey, I have this new technology I want to do, but you're going to go broke using it. What a great idea. I mean, that's not going to work, right? So I have to come up with projects and pilots that are clinically but also economically feasible, because we all work on a percent of collections model. So it's not like we're getting all this supplemental income to try new stuff. That's my job. I get that. And then anything else that I try, I have to prove a financial potential return on investment for them.
Gotcha. How much flexibility do you have in terms of like the length of these pilots? Like how long do you get to test something out before you kind of got to start making the decision of this is a winner or a loser? And I guess while you're doing that, you've got the blessing of the hospital system. Are they really kind of laying off and trusting you, or are they kind of always poking in saying, how's it going? How's it going? Do you have any proof yet? And what's that experience been like?
I've been given a ton of flexibility. I mean, it's really amazing how supportive our system is being. It really starts, really the idea for this clinic came from our CEO. So there's really no one above who I work with that could trump what we're trying to do. And because of that, it's been basically like, hey, you do what you think is best. We trust you. We've given you this position. And I think if I came back and said, oh, well, we'll have some ideas for you in 2 years, well, of course they would say, hey, that's not going to work.
Right.
My internal goal has always been, if I can get the volume of trials up, that I like to make a decision in 3 months and implement in 6 months on whatever we try. That's kind of always been my internal goal. And certainly if we could do it faster than that would be awesome. But some of the things, especially right now that I don't have my clinic, it's taking a little longer to get volume up that I would like. So for instance, with CellScope, I think if I'd had my own clinic, a place to distribute these devices, I probably could have got a critical mass in a month or two and then been ready to scale up even faster. So until the clinic's built, things are slower than I'd like them to be. but it's still fast, and it's still way faster than if you were trying to trial it with, you know, even 2 or 3 clinics, just getting agreement on how it's going to work. And we don't dictate like that anybody would try any of these things. So if it's not for a group, they say, oh, that's just not going to work for us, we're not interested, that's fine. Like, you're not required to do anything that we do. But we do want you, I mean, there's no reason that health systems shouldn't leverage their influence on payers, the market, whatever, to get to try new things. Because it's so much easier than when I was in Abilene and there was just 5 physicians in the group. I mean, it's a different proposition than, hey, I'm a member of a huge group of pediatricians. So we should be leveraging that to innovate and do new things for our patients. Unfortunately, I think a lot of people are saying they are, but they aren't, and that goes for us too. I mean, this is a new thing for us, so we're still learning how it's going to work. I think there's a lot of good work going on across the country, and we're just a part of it.
Gotcha. So the big setup for the show was about how you were taking the patient feedback, and really that's just another big experiment in the long lines of things you're experimenting on with the clinic. So let's talk a little bit about that. How have you incorporated feedback from your patients, and how's that worked out for you so far?
It's been really amazing. You know, I think to truly do something different, it doesn't make sense to not have all the parties involved at the table early. And so to sort of have designed this whole clinic and then be like, well, I hope it works when we go out there, I mean, I think would have been really risky and dangerous. I would have taken a really big risk of losing this opportunity. And so I, from the very beginning, said, hey, we want to do things that make sense for the system and make sense for our providers, but primarily it has to work for the patients, or this is a non-starter for us. And so I was able to sort of use the community that I've already built online. And so that's primarily for me, that's Facebook. And so that's one of the things that I've done a little bit differently than some of the other providers who are on social media, is I've utilized Facebook a ton. And so I have a really strong community where there's a lot more back and forth with patients. And I think most of my Twitter followers are industry, other medical people, that kind of stuff. And so that wouldn't be a great place for me to get the feedback I need to, but on Facebook I can. And so really for years, even before this was a dream, I would frequently, you know, every few months just roll out like, hey, how would you make your pediatric office better? And I've been sort of cataloging those ideas mostly in my head. You know, it's nothing formal, but certainly people have ideas and they have frustrations. And I think if you empathize with them, instead of just saying, well, pushing it off to the side because that wouldn't work for me, but instead you say, hey, that is an interesting idea. I don't see the way to accomplish it today, but let's file it away. And then later on, we may come back to it as technology develops or whatever. And so you could have easily seen a scenario where 5 years ago, you threw that out there and someone said, well, I hate that I have to go in if I just want my kid's ears checked. Why can't I do that from home? Well, now that the technology is there, then we have a solution for that. And so that's just an example of something that you can be gathering information. Even if you can't fix the problem now, you could say, I sympathize with you. I empathize that that's a struggle for you, and I can't fix it today, but I promise I'll be looking for that solution, and then we'll come back to it later. So I've developed a lot of trust by doing that, and trust that patients' ideas would be heard, respected, even if they differ from mine. And then we'll come back to them and we'll look at those later. So a good example of that is years ago, maybe 2 or 3 years ago, I threw out this question. And one of the things that really, this tangent that came off of it was the experience when I bring my newborn in is scary, and I'm not comfortable with it. And so this idea that the newborns came through the main waiting room, there was a whole bunch of sick kids in there. The office was loud, cold. I don't have time to nurse my baby in there. And so we actually, because of that, in the new clinic, and because we were able to build it from the ground up, we built a dedicated space for newborns in the back. And so basically along this wall sits the main rooms, the nursing section is in the middle, and then off back behind, sort of almost back by the staff area, there's a room that's about 50% bigger than the rest of the rooms. It's got a nursing glider in there. It's got its own temperature control, and it has a back door to where the parents can drive up, and they're going to text us care. So then we'll go back and let them in the back so they can go straight back to the nursing and baby room.
Oh, that's awesome.
And so basically that's the kind of things that we are gathering from Facebook. And it might be something as basic as that, or it might be something as really sophisticated as, you know, throwing out an idea for, hey, what technology company is your favorite and why do you use them? And so one of the big things that came out of that was people, of course, love Netflix, but what they really liked about Netflix was the recommendations that they got for new stuff. And so we're in the process of developing a system where we're cataloging all of our videos and content that we've made, and we are going to be able to recommend, if someone watches something, we'll be able to recommend something that might be related. So for instance, if a child has a runny nose, the parent asks for, hey, what do I do about my child's runny nose? We can actually present to them all of the data that we've created as Cook Children's for years, and serve that back up to them as a menu for them to choose from when they get home, so that they can watch that information as they get home. So they don't just leave with my verbal instructions. They go home with hearing what I've heard, then having a video where I've recorded what to do, and having a blog post that they can read, and all of this served up to them so that they can get more information when they get home. So I think the most basic way we've used the Facebook is to gather the shared information. But then the second thing that we did, sorry, I'm just going to go through it. It's a long topic, but a long speech, I guess. So then I took my Facebook followers and I sort of watched and paid attention to who was the most engaged and who was coming up with the biggest, sort of craziest ideas. And I then found some of those people who actually sit in or nearby where my new clinic is going to go, and actually put them on a patient design panel. And so we were able to get this really amazing group of patients that are so diverse. We have a mom who's on Medicaid, we have single moms, we have grandparents, we have this big mix of people. And what I've done is then pulled them out and sort of asked them, hey, would you be interested in really helping me design this clinic and making it special? And then what I've done with them is as we've not been open, I've submitted questions to them about once a month. And I'm getting not quite 100%, but near 100% response rates on those questions. And so I posed that question about technology to them. And one of them said, oh, well, we just got back from Disney and we love the Disney bands, and like, how could we incorporate that into the clinic? And so, it's not anything that I think we can do tomorrow, but you could certainly see where you could create an experience. And I saw Chuck or somebody was talking on the tweet chat about, making it a showcase, or putting the patient on stage. And I think that we could certainly, that's something that we could easily put together if we have an app that allows for location sensing, and then we can scenography. Thank you, and then we can build an experience for the patients that is really spectacular and really stands out. So those are the types of deeper engagement that I'm getting from that patient design panel. And then we'll have them in once the office is open. We'll have them in for lunches, and we'll bring them in as a group and one at a time, ask them how things are going and get constant feedback. And I think in order to really make something patient designed, you have to ask them first, and then you have to try something, and then you have to ask again and iterate constantly. I think this is going to be, I have to build a staff that's flexible and agile as I am all along the way. Like, I can't have a receptionist that's super rigid or a nurse that's super rigid, because then we're done. Like, the second that person, we're going to go to the lowest common denominator in the office. So we are searching out people who are sort of the best in their field, but also the most willing to sort of think outside the box, because we want to have a whole culture in the office of agility and innovation.
Yeah, that's amazing. So going back to the hospital system, then usually what we tend to come across in the hospital system is very risk averse, very afraid to try new things. So I want to get into a little bit of the culture at Cook's and the CEO who came up with this idea. What do you think is different about Cook's that enables this type of approach and enables the leadership team to accept some risk for the potential reward of trying these new things?
I think there's a couple of things. Number one, our central promise for for our institution is that every child's life is sacred, and that we will meet those children wherever they are to provide whatever care they need. And so I think because telemedicine is going to be a big part of the future of health, that it fit very well with that, because we will do everything we can to learn how we can provide care for these children quickly, efficiently, but still maintain that quality and personal connection. And so I think because that's our promise as far as care for patients, and we know that digital health is going to be a big piece of that moving forward, it made sense to put a place where we could really try that out. And so I think it fits well with sort of our promise towards patients. And then secondarily, we are a very much physician-run institution. And so all of our boards have over 50% physician involvement. So I sit on our big board of directors, and over 50% of those members are required by bylaws to be physicians. Our executive panel from that is 5 physicians. They meet every week. And then we have, all the different committees and everything are physician driven. So, I mean, I sit on the practice management committee, and, I had to run the meeting because the leader was out last week. And I'm not really a meeting runner type of guy, but also it's just important to the system that we always keep that sort of physicians driving the system. Well, on top of that, we've also been able to really recruit a really strong group of physicians that really want to do what's right for patients and what's best. And so when you combine all that together, they all wanted to try these new things, but they're also a little scared of doing it for the first time or what it would do to their bottom line. And so I have been so shocked at the support I've gotten from other physicians, even physicians that I will technically, our geographic areas will overlap. So we'll technically be in some competition in a sense for patients, but they've all been really excited. Hey, we're really excited for you to try these things because we thought about them, but we just didn't know how to get it going. And it's given me sort of the language and the know-how to sort of push the ball uphill. And I think unless you've been given a little bit of power or leeway to do that, you can't do it if you're just the pediatrician who's like, hey, I have this idea. Well, now I'm in a sense not only empowered to do it, I'm almost required to do it. And if people aren't looking at me and going, oh, are you sure? Then I'm probably not pushing the edges enough. Sure. And now that everybody has sort of seen that, I mean, and it's not just our brand new physicians who are interested in this stuff. It's our nearly retired. I mean, one of our earliest adopters of telemedicine is a guy who is in his, he's in his late 60s, I think. And he's super excited about using telemedicine for his patients. And his office, along with his 2 junior partners, called me and said, we want to be one of the first to pilot telemedicine. Once you've tried it, can we get on the list? Sure, let's do it. And so he's doing it with his patients, and his partners are doing it with patients. So it's not a generational thing. It's not a, it's just a mindset thing of this is what's coming. So let's figure out how to do it in a safe way for our patients. And we see that, there's plenty of companies in Texas who would love to provide telemedicine for our patients and take the revenue and do it in their own way. And I think that we as providers have to step into that and say, we are still should be the primary source of care for our kids. And if we're not providing that service, then shame on us for not providing it. We can't really complain that they're going somewhere else to get it. And I think if you rewind back to retail care, that's kind of where we were about 5 years ago. Is a lot of pediatricians just said, oh, well, our quality will win out. We have the relationship with patients. And we saw that didn't work out so well. And we saw our volumes of ill visits dropping. And I think now...
And that...
Yeah.
I think, Justin, that was a great point that you made, is that innovation patients at this point, especially patients with kids. So my youngest is now 19. Therefore, I've been having kids that age for a while now. But what we know is, as young parents, nobody cares what your doctor says or whether this guy says or that. There's nobody being put on a pedestal. It's who can solve my problem right now. The kid is crying now, and he might not be crying 3 days from now, or he's sick now. I need to get my problem resolved. So as you look at from a business of healthcare, which is what we talk about here, there's so many lessons that you've just taught us, right? So number one, as Don was saying, we tend to lump hospitals and groups, things like that, into risk-averse kinds of areas. But I'm not quite sure if it's true risk-averseness at this point. 10 years ago, it might have been. What we're looking at is there are 3 building blocks of innovation. The first is, have you thought about the fact that you want to do something different? Do you want to innovate, or do you want to say, look, I'm fine where I am, my revenues are okay, I'm not really going to try to go change anything? And there are a lot of possibilities. Anybody who's assigned a chief innovation officer or a chief medical innovation officer, et cetera, has already at some point, either on their board or within some organization, said, we care about innovation. Now, that taking away the risk averseness for a second, what's the second big problem? The second problem is, okay, if I want to innovate, what's my strategy for innovation? If my strategy is internally focused, top down, where my senior executives already know what the problems are, they know who they can go pick. Our problems are mostly internal, and that's the strategy that we should set up. Well, your approach will look very different. Clearly, you guys said, we have executives, they have a pretty good idea of what they're doing, but we're going to make this externally focused, and not just externally focused from other people like consultants and smarty pants, et cetera, from the outside. We're just going to listen to the people who actually need our services. So when you embarked on that strategy, it wasn't accidental, right? It didn't just pop one day and say, what should we do? It's no, we want to do this. And the people who know best what they would need are going to be the patients. So first you made the decision that you wanted to innovate. And that's what people can learn from you, both on the solution side as well as on the provider side. The second thing is strategy, right? And then saying, okay, this not internal, but external. Not looking for guidance from other physicians, but looking for patients. And there are bunches of ways. And so there's no right way and there's no wrong way here. But this seemed to be working out. And the naysayers, you can at least say, hey, you guys, we're not just a 3-doc group doing this. This is a big group. I mean, 100 docs in anybody's world is a reasonable sized group. And we're pulling this off. Therefore, shut up. We know that this will work. Don't tell us that it won't, right? That you can at least say that now. Now, the third and fourth things, they get very interesting. The third problem that we often have in an innovation model like this, which I'm learning from you here, is workforce development and understanding how to make sure everybody talks about culture and how culture, is very important, and you have to be able to make the culture work. But really, culture starts with workforce development. Who did you hire, and what are the people that you hired? What do they think about your innovation strategy? Only then can you have any impact on culture over time. So it seems what you're teaching us here is that hiring process, and I love the example that you gave with respect to making sure even the receptionist, and I shouldn't say even I mean, that's a very, very important part of the company and the organization that you're setting up. So it starts with the receptionist, goes everywhere else. So tell us a little bit about the workforce development. That's a struggle everywhere. As we talk to chief information officers, security officers, innovation officers, they all have problems saying we can't hire the right guys. Where did you go to find some of the people that you found? Are you building that team and saying, well, I'm just going to find people that are good in customer service and I'll teach them how to do medicine? Or do you go to companies that are doing med tech training and then teach them how to do better customer service? What does that model look like? And then once you tell us a little bit about that workforce development, we'll talk about the fourth piece, which is how do you tactically, once you've got the people in place, you've got the strategy and you've got the approaches, how do you tactically go about doing this? Do you go to vendors and seek their help? Do you go to your local associations and seek their help? Do you go tying together with other consultants and physician consultants in the area? So talk to us a little bit more about that workforce development. I don't think it's as easy as you made it sound.
So for me, I've been really blessed in that I've worked in a bunch of different environments, and I have developed relationships with people, and I sort of know how I have ideas of what I want my nurse to be like, ideas of what I want my nurse practitioner to be like, and everything. And because I've moved around a little bit, and now it's becoming common knowledge that this is going to happen for me, and it's something that I've always kind of talked about with people I've worked at along the way. Wouldn't it be cool if we could do this? Wouldn't it be cool if we could just kind of dream with people? So I've been able to hear back from people, their thoughts, and I sort of know of the people I've worked with in the past who thinks like I do and who's ready for this, because it's really a matter of being ready when you come in with a mindset. So I kind of unofficially, because we haven't posted any jobs yet, but kind of unofficially have an idea of who may fit into several of the roles that I already have. And secondarily, I agree with you that we especially for certain jobs in the office, there may be some benefit to getting somebody who's outside of medicine, because I don't know how many times I've gone through a drive-through and talked to the drive-through worker and been like, this person would be 1,000 times better receptionist than the receptionist I have in my office. Not here where I am now, because I'm not slamming on anybody that I work with now. But in the past, you know, I'm like, oh, I mean, I would love to pay this person probably more than they're making now, and I could teach them how to schedule a person in the EMR, and they would be 1,000 times better. So I think we've got to get out of this mindset that medicine is really hard, and that if we don't get someone who's like already like at the top of their, you know, game in whatever field they're in, that we won't survive. It is hard, but they're all teachable things. And sometimes I can't teach the person who's best at scheduling a patient in the ER how to smile and be nice and tell the mom when she comes in, hey, I'm so sorry your kid is sick. And sometimes that drive-through worker, I get the impression that they could do that 1,000 times better than the person who's been to medical receptionist training or whatever.
So Justin, it sounds like, sorry to interrupt, but it sounds like what you're teaching us here is something that the best world-class companies understand, and that is you have to recruit. You can't just wait for people to come to you. So
yeah.
And I was just smiling because the person you saw there, you could actually just talk to them and say, would you rather be doing work at a medical office instead of here?
Right.
And that's recruitment, forward-facing recruitment. Yep. Now, typically in an environment like medicine, especially at hospitals and large systems, major executives are often recruited. Physicians are often recruited, right? You want the best of the best in those areas. Yep. But it is not common to be recruiting what we think of as the lower positions, when we know those positions are often far more important from a customer service and retention and growth of revenue perspective. And so, I mean, that's a great lesson learned here.
I can tell you, like, I had an MA when I was out in Abilene, that I'm doing everything I can to try to get her to apply for my MA position in this practice. And she's moved off out of state, but I'm just knowing, like, the patients loved her. She kept me on schedule, you know, just things that are hard to do for someone like me who's super driven and has a motor that goes 900 miles an hour. Like, I have to have an MA that can do that, or I'm never going to be satisfied. Like, not that I'm necessarily that hard to work for, but also, like, they're not comfortable if they're not comfortable going with some pace but still being nice and friendly. And so, yeah, I agree. I think we have to always be looking for who's out there. You know, you think about it, like, what's the cost of putting that drive-through worker through medical reception school, and what's the ROI for that if they do turn out to be really good? I mean, your ROI for that would be 1,000 times if you got the right person in that receptionist job. So yeah, I think those are really good points. And then I think also that you have to be if you're going to want to do this, you have to be someone who sets that culture, and you have to be somebody that people want to work for. So you know, I can't be a jerk to everybody that I've ever worked with my whole life and expect that person who's really good to want to come and work for me. And so I've developed relationships with these people who are calling me over years, and they're excited about coming because they know that I have big ideas, and they have big ideas, and they know that I'll listen to them and try what they're thinking too. And I think over time, it takes building culture is not, you know, obviously you just decide you're going to have a good culture and it happens. It's a time consuming, and it really requires that you be committed to that day in and day out.
Yeah, right. Absolutely. So as we're heading towards the end of the show here, I wanted to get back to your innovation model, your trying things out model, and you know, specifically for these things that you've gotten feedback from the patients on, how are you going to measure them, and are you going to keep this patient panel, if you will, together for ongoing evaluation of the practice, just like we talked about the ongoing, workforce development? What does it look like in 6 months?
Yeah, so a couple of things. We are going to definitely keep the patient panel going. I think that's an important part of the development, and I think so many of the good ideas I got for how we built the physical space, I'm going to need them to continue helping me build out sort of, you might think of it as like the digital space of the office and what offerings we have in a digital world. And so, and they've already helped with that, but I think as new technologies come available, I'm going to need them to give me feedback on whether it's something they would use or not, and help me come up with use cases for them. So yeah, we'll definitely keep that going. It'll actually probably ramp up to where I'm asking them more often, and then having them in the clinic to sort of walk around and help me feel out how things are working once the time gets here. We've also,
it sounds like one question, Justin. It sounds like the patients are pretty responsive to you without you having to offer them any incentives or anything, right? Are you giving them a discount on care or some freebies, or these people are just like, they're so happy that a doctor or a clinic is listening to them, they'll just talk to you because of that?
I think, and I did tell them, hey, you'll get the friends and family like cell phone plan where you'll have my number and you can call me.
Nice.
So
can we get that too?
Yeah, sure.
Yeah, we've got a 2-year-old.
Oh yeah, wow. So yeah, you know, so that just, I mean, I'm just sort of said to them, like, I want to be available to you. You've done a lot for me, but secondarily, I want you to call me if you have an idea. I don't want you to wait till the next time I roll questions out. So I want this to be sort of a constant feedback loop. So yeah, certainly they're going to get that benefit. But the reality is most of them would have done it without that. They want to have someone who, you know, the community, there's not a lot of pediatricians in the area. So the community is really excited to have, and we picked that market specifically because of that, because it's not a place we had been before. But they're really excited to have this model of a clinic in their community. So that because of that, they're more than willing to give up some time and some ideas to help build it, to make it to what they want it to be. And I've really, I mean, our tagline is it's a pediatric clinic designed by you. And so that's all over all of our shirts that we've made, and it'll be all over everything in the office, all our mugs and everything else will say, you know, a clinic designed by you. And so, you know, they're excited about that. And it's just, no one's ever come to them and asked for advice. I forget what the question was.
It seems so odd that, you know, we've been doing patient care for so long that it would seem weird to ask patients. Now, of course, to be fair, we run these, you know, there are HEDIS measures and scores for patients. There are patient satisfaction scores. You know, there are big companies like Gainey that manage these kind of patient satisfaction numbers. You're not really talking about, do you still run a patient satisfaction survey, or have you replaced that, or replace this feedback with patient satisfaction? And that's how you know.
That's a great question. It reminds me what I was going to say next. So yeah, we still continue to do sort of the 8-question survey that we give at the end of each visit. And that's how we measure for our system patient satisfaction and engagement and that kind of stuff. And that will continue, and that will happen in my office just as a means of measuring is, and be sure that, you know, we're not doing something that's inappropriate in our clinic, and make sure that everybody's still happy. But what we are going to continue to do is tighten up sort of our feedback loop a little bit. And so everything, we're going to actually shift everything to, you know, sort of a paperless check-in and check-out. And so the parent will get a tablet that they're carrying around the office with them. And once the visit's completed, we may ask really pointed, like, how was your experience at check-in for a month? And just gather that information for a month, get feedback on that. And then, you know, the next month we'll move on to something else to get feedback, really specific feedback about how we can make things better and change. And then secondarily, that's a way to get feedback on what we're already doing. But I also want to continue to have broad ways of getting feedback. And so we've really toyed around with, and I think we're going to have a really cool feedback mechanism on the website where parents could go in, leave sort of a suggested service line or suggested idea for the clinic, and then allow through like a discuss or like a, you know, point, you know, upvoting system, you know, allow some of the best ideas to rise to the top. And parents could, you know, on their tablet, they could be filling those in while they're in the office. Once they get their check-in and stuff done, their tablet, you know, could prompt them to look at that page of the website and leave a comment or suggestion there. So that it's right front of mind, like, oh yeah, it would be cool if you could do this. And then if people upvote it, I mean, that's what I've kind of gone to administration with, is like, I may come to you with a crazy idea, but I'm only going to come to you when a patient has suggested it and 10 people have confirmed that it's a good idea. And if it sounds crazy, it's not my idea necessarily. Like, I'm not just, I think people like first thought like, oh, this dude's just crazy. He's got all these crazy ideas and he's going to make us do all this crazy stuff. And I'm like, no, we're only going to do it if it makes sense for the patients and it makes sense for us. There may need to be some massaging to make it make sense for us, but if they've demanded it in a sense, how can we not figure out a way to meet that meet that need or meet that request.
And that was the fourth piece. So when you think about, so first was decide to do it. The second is establish a solid strategy, get your workforce ready. The fourth thing is how do you decide the tactical things to do day to day? And you just taught us that, well, just use, but based on your strategy, if you're looking for external guidance from your patients, let them drive it. You have to put the systems in place, you have to put the approaches in place, and then you have to actually do it. Right. This is where a lot of strategies fall, is that tactically, you don't tie back and say, well, we decided to listen to patients, but now we're just going to, use some surveys, et cetera, and we'll look at them once a month or once a quarter, which is crazy. You have to integrate that. So, I mean, you guys have done this so beautifully with all four prongs here that the idea of success is almost taken for granted, because you're listening to the people who want your services and they'll do that. Could you give us a mix? What does your patient population mix today look like? Mostly Medicaid, small part Medicaid, mostly paid? What does that look like?
Right now, I'm probably about, of course, I'm mixed. Well, actually, technically right now, I work 2 days a week in a Medicaid clinic, so I'm probably more Medicaid than private pay right now. But my suspicion is I'll probably run about 30-70 Medicaid to commercial, maybe 40-60, it depends on how it goes. I will have a mid-level in the office who can help me with some volume. So we definitely want to have enough of each population to where when we try something, we can sort of then, so in the system, we sort of run two, in a sense, types of clinics. We have our neighborhood clinics that are mostly Medicaid. We have our commercial clinics that are mostly commercial. And there's some overlap on both, but I want to be able to try things and then go to the director of my Medicaid clinic and say, hey, we tried this and the Medicaid population really loved it. You should take it on. Even though it hasn't been tried in one of your neighborhood clinics yet, I have enough critical volume of visits done this way or whatever it is that you should try it for your clinics. And I think that gives us, providing that mix gives us the opportunity to do that. Whereas if I was 5% Medicaid, or I decided I was going to see like 100 Medicaid patients and then close my panel, we couldn't do it that way.
No, and the reason why I was asking for that is that what we've heard a lot, and as part of my part-time advisory work at AHIP with the insurance plans, you hear this all the time. Oh, that would work in commercial, but it would never work in Medicaid.
Yeah.
The Medicaid population somehow is from the moon or Mars, or these aren't real, the same kind of people that live in the communities. Of course, hopefully you can tell by the tone of my voice for the audience that's silly, right?
Right.
This population. You hear things like, well, the digital won't work because they're not heavy users of smartphones, or, this won't work because they can't get to that particular office. What I'd love to see, and this is where, it goes back to the original premise, is if you're listening to the patients and the patients are telling you, damn it, we want it, we will use it, just give it to us and let us try it. Are you seeing that the Medicaid population is as vocal? I would imagine the answer is yes, but tell us, from a feedback perspective, is it about the same?
They are. I mean, some people are very surprised at what the uptake that they may have for technologies. And sometimes they may be more dependent on that new way of connecting with me than a commercial payer that has a stay-at-home mom that is like, well, I don't really need telemedicine because I'll just bring my kids in. But the Medicaid family who has two working parents, or the mom can't get off or whatever, she may be more dependent on the technology. And so what I see is, like, one of the good examples of that is direct messaging through our portal. I would say that it's probably 50-50 on who uses the portal to communicate with me, Medicaid versus commercial payers. And they use it really well. Nobody abuses it, and if they did, I would say, hey, I can't answer this question here. I need you to come in. And they, I suspect that because of my openness to do that and my relationship with the patients that I have, they would understand that I'm not just out to make them come in to get paid, that it's about their child's safety, getting the best care for their child. That's not, I think technology are smartphone driven. A lot of our Medicaid patients rely on their smartphones for their internet connection at all. I mean, I think the Pew Research is starting to bear that out, that maybe their only source of connection to the internet is a smartphone. So they're very savvy with using a smartphone. So I'm not requiring them to have high-speed internet connection at home with an independent webcam. I think their uptake will be just as high, if not higher, than the commercial payers. And I think the real key is getting our payers on both sides to start paying for some of the services provided this way. And honestly, in Texas at least, that's probably easier with our Medicaid populations than with others. And it's certainly easier in my situation because I have the cell phone number of the health plan director, and I can be like, hey, you need to pay me for this, and I'll show you how it's going to save you money in the long run. And they're like, okay, well, you're our first pilot for this. Let's go. And so, you know, it's certainly easier for me to do it that way. So that's one of the main reasons why, even though I'll be in a neighborhood that the zip code would not bear out that we'll have a huge Medicaid population, I know I'll have commuters in who want to try the services from that population.
No, that's beautiful. And in fact, in Medicaid, that's if you're able to attract people, obviously that makes a big difference. So what are the universities around your area? The reason why I'm asking is that, I mean, the model you're trying here is new enough. I mean, if you were doing this in Boston next to Harvard or MIT, you'd have students coming in and reviewing what you're doing. Clearly in your area, there's got to be some universities. Could we suggest that students come in and, you know, if they're taking health IT programs or they're taking classes in their healthcare management programs, that they come out and visit and see what does a clinic built by and for patients look like? What does a feedback pattern look like? How could you kind of train people to do this at either colleges or universities or even other organizations near you?
Yeah, we have a really great working relationship with Texas Christian University, which sits right here near, you know, within a few miles of our main medical center. And we actually a really cool, and a lot of, I think, what we've done from a culture standpoint stems from that relationship, because we've started a pediatric leadership, it's Advancing Healthcare Leadership in Pediatrics course with TCU. And we met for a whole year. And we finished up our first cohort in April. I was a part of that cohort. There were about 30 of us physicians involved in the cohort. And a lot of it was about, you know, learning leadership skills, how to have difficult conversations, all of those things. But then there was a big chunk of it on being entrepreneurial and innovation. They've asked me to come back and help lead the first class, to sort of come back and say, like, look, here's what we're already doing. We're not just talking about this stuff, like this is reality, and you can get these projects pushed through the system, get stuff done. And that relationship is really developing. And so I certainly see that as a future goal of ours. In fact, I'm meeting with some of the TCU folks next week just to talk about, like, how could we start to develop some courses around some of the ideas that you're talking about, so that then we could not just teach locally, but then potentially have web courses and things like that available for you know, other institutions that might want to put their young leaders or even their experienced leaders through a course that would sort of teach them about healthcare entrepreneurship and innovation.
No, that sounds great. So we'll let Don take it home from here. But it sounds like, Don, we have at least one or two more HCBizes we could run with the folks from TCU and see what they're doing, and maybe even get on, you know, one or two of either the loudest or the most interesting patients that Justin has. Get them on here, and say, you know, Justin has great ideas, but he's not doing these things we want him to do, and even learn in a more broader approach. This is one of the things that Mandy Bishop over at Dell has talked about. That she complained a little bit at earlier this year at HIMSS, that, you know, all of us are over here pontificating. Even we have doctors involved, et cetera. But what about the patients? Why aren't they talking about healthcare business? Why aren't they talking about the tools that they need, et cetera? So when we get a patient or two on, maybe Mandy will come back on and help participate in that as well.
No, that could be a lot of fun.
Yeah, so Justin, I want to really thank you a lot I learned a lot today, and it helps us establish our thinking. And I've got to run off to this the Cancer Moonshot event that I'm at here at Howard, but I'll let Don take it away from here.
Awesome. Yeah, I'm just in closing out. As I said, I think that the model that you guys are taking is great, and I think it's one that a lot of other organizations can look to. And it's decide you want to try some new things, and then how do you isolate it so you can mitigate that risk? And I think kind of taking someone forward looking like you and giving you some leeway to run in a controlled environment, but one that they're really going to stay hands off and let you do your thing. I think that's a great way to try some new things and get the benefit of finding out what the role without the huge, the risk of trying to roll something all at once to all of your clinics, which I think people would be right to worry about. So when does the clinic schedule to open?
Well, that's a moving target a little bit, but I'm thinking October, early November.
Okay.
It's all about construction now, and we're waiting on the developer to give us the shell. And then once my team is in there, I can push a little bit harder and get things moving faster. So I think October, November. I think after that would be definitely a cool time to get back on and let you know how it's going.
Yeah,
give you an
that's
update.
exactly why I'm asking. Yep, because it's good to see see it on the way in and see what the plans were. But I'm sure you're going to learn some huge lessons over the next 6 months, and I think it'd be awesome to have you back on and talk about it. And yeah, certainly. Think about adding some patients or possibly some people from Texas Christian. I'd be open to all those ideas. So thank you so much.
Yeah,
very refreshing to hear someone doing what you're doing. Have a great day. Thanks, Shahid, and enjoy the rest of your day as well.
All right.
All right. Thanks, guys.
All right, guys.
Bye.